question answers as well as MCQs. And MCQs are from beginner level to the expert level. So as to you can do your self-assessment. You can use the code Dr. Divya 20 for the first free live class. We have few subscription plans, the basic, standard, and the mentorship program. The mentorship is a wholesome program of 12 months, and we offer you at a special discount rate of 50,000. So here, in addition to the pre-recorded class, live class, as well as live doubt clarification, quick revision, we also offer you personalized one-to-one guidance as well as notes. So you can use the code Dr. Divya 20 for discount on the subscription. You can as well book a slot for personalized counseling session using the code. And about internal exam marathon classes, which we have started since April 22nd, it's for a duration of 45 days. So here we offer you quick revision of all the important questions, quick revision of volatile facts, as well as multiple choice questions will be covered. And this includes the syllabus for all the university exams. You can use the code Dr. Divya 20 for first free live class. So we'll start with the Upper Limb Marathon Series 1. So here today we will be addressing these questions. That is, we have the long essays. You have the long essays, important long essays, short essays, as well as short answers. So we begin with the essay questions. So first question is axillary artery. So any artery, you have to note that we have to answer it under these headings: origin, termination, the course, paths and relations, branches, as well as applied aspects. So coming to the origin, axillary artery begins as a continuation of the subclavian artery at the outer border of the first rib. So this is the first rib. So at its outer border, it begins as a continuation of the subclavian artery. And it runs the axilla and it terminates. So that is the origin. Okay, so you can write origin, that one. And termination is at the lower border of the teres major, where it will continue as brachial artery. So this is the origin and this is the termination. The course of the artery. So here, after it originates, it runs in the axilla. Okay, so in the axilla, it forms a part of the content of the axilla and it terminates at the lower border of teres major muscle. So here, this axillary artery, in its course, it is divided by the pectoralis minor muscle into three parts. The first part, the second part, and the third part. So the first part extends from its origin, that is from the outer border of the first rib to the upper border of pectoralis minor. And the second part lies behind the pectoralis minor. And the third part is from the lower border of the pectoralis minor to the lower border of teres major muscle. So these are the three parts of the axillary artery. So before we go in for the relations, we just need to understand here, this is the axillary artery which runs in the axilla. So here the cords of the brachial plexus, they are related to the artery. So here in the upper part actually the medial cord and posterior cord. Okay, so lateral cord will be lying little posteriorly and medial cord will be towards the medial part and posterior cord will be towards a little bit towards the medial. But here in the second part, they lie in the proper relation, that is lateral cord will be in the lateral, medial will be medial, and posterior cord will be lying posteriorly here. Okay, so when we take a section and when we see, okay, so here if you see here, so this is the anterior relations. Okay, so here you can see the map. So anterior relations. So this will be the medial relation, this will be the lateral relations, and this is the posterior relations. So when we take this first part, okay, this is the first part. So first part here, the lateral cord and the we will go from anterior. So we have the skin, the platysma muscle, the supraclavicular nerve. So this is basically in the upper part of the thoracic region. Okay, so we see that, and then we see the deep fascia. Below that will be the pectoralis major muscle. And piercing the clavipectoral fascia, we have the thoracoacromial artery, lateral pectoral nerve, and the cephalic vein. So this is the cephalic vein. So this will be piercing. Cephalic vein enters this, drains into the axillary vein, whereas this branch, that is the thoracoacromial artery from the axillary artery, it will be piercing and coming out, and we have the lateral pectoral nerve. So these are the structures anteriorly. Posteriorly, if you see, this is the intercostal space, first intercostal space. So the first rib and the second rib. And we have the intercostal muscle here, then the serratus anterior muscle and the nerve to serratus anterior. Okay. And medial cord here, I told you in the upper part, medial cord will be posteriorly. Okay. And posterior cord and the lateral cord will be lying laterally here. And the axillary vein will be the medial relation. When we see the second part is behind the pectoralis minor. So here if you see skin, we see the deep fascia. Okay, so this part is in the axilla. Pectoralis major muscle and below is the pectoralis minor. So this is the axillary artery. So this will be the anterior relations. Posterior relation will be the subcapsularis muscle. And here all the cords lie in the proper orientation. So lateral cord will be lateral, posterior cord will be posterior, medial cord will be medially along with the axillary vein, and a branch, that is medial pectoral nerve or from the medial cord, can be seen. And here on the lateral side, we have coracobrachialis and the short head of biceps. So actually the relations of the artery, you can just show by the diagrams. You don't have to draw the diagrams as well as explain the whole thing. Again, enumerate, okay? Only thing is when you are writing, you can mark this like, all these relations as anterior and list it out. This side you can mark it as medial relations and list it out. This side you can write lateral relations and list it out. What are the laterals? So that will be easier. It will be like a diagram, says it all. So the third part relations, here we divide into two parts, the upper part of the third part and the lower part of the third part. So in the upper part, we see the skin, the superficial fascia, the deep fascia, then the pectoralis major muscle. Okay. And posteriorly, there is subcapsularis. And this is the axillary artery. So on the medial side, we are seeing the axillary vein and the branches from the medial cord. That is the ulnar nerve, the medial cutaneous nerve of arm, and the medial cutaneous nerve of forearm. And on this side, laterally, we see the lateral root of median and the coracobrachialis, short head of biceps, and the musculocutaneous nerve, which are the branches from the lateral cord. And here, in front of the axillary artery, the lateral root of median and the medial root of median would have joined to form the median nerve. Okay, so that is seen here. And posteriorly here, we have the branches from the posterior cord, mainly the radial nerve and the axillary nerve. Then in the lower part. So lower part, if you see here, only the anterior relations will change here. So you can see the skin, superficial fascia and deep fascia. So here you don't see the pectoralis major muscle. And medially, we see the axillary vein, the medial cutaneous nerve of forearm, ulnar nerve, and the medial cutaneous nerve of arm. Posteriorly, the latissimus dorsi muscle as well as the teres major muscle is seen. Laterally, we have the median nerve. Okay, formation, because the median nerve would have crossed there. And this thing, coracobrachialis and the short head of biceps. So these are the relations of axillary artery, which is very commonly asked as a 5 marks or in a long essay as a part of the long essay question. So this is just to summarize schematically, you can show. Right. So branches. The branches now we say from the first part, the second part, and the third part. Okay. So from the first part, we have one branch. Okay. That is called as the superior. So it's like according to the branch, the number of branches also comes according to the part. Basically, first part, 1 branch, second part, 2, third part, 3. So first part, we have the superior thoracic artery. From the second part, we have the thoracoacromial artery and the long thoracic artery, okay, long thoracic and thoracoacromial artery, which will divide into a pectoral branch, clavicular branch, deltoid branch, and an acromial branch, okay. So it divides into 4 branches. So this is the thing. And from the third part, we have its largest branch, that is the subcapsular artery and anterior circumflex as well as posterior circumflex humeral artery. So those are the branches from the axillary artery. So when you write about the branches, you can make a column like this and just mention from the part, which part, the branch and the area of supply. Okay. Because branches itself is also asked, like a 5 marks or a 3 mark part. That time it is easier when you write it like this instead of writing sentences and repeating the same. So superior thoracic artery, area of supply will be the pectoralis major and minor muscle and the medial wall of the axilla. Thoracoacromial artery, the pectoral branch supplies the pectoral muscles. Deltoid branch supplies the deltoid muscle. Acromial branch, it will take part in the anastomosis over the acromial process of the scapula, and then clavicular branch, it supplies the sternoclavicular joint and the subclavius. Lateral thoracic artery supplies the pectoralis major and minor, serratus anterior, and the mammary gland. Then from the third part, the subscapular artery, it will also give a branch, which is circumflex scapular. So this will take part in the scapular anastomosis, and subscapular artery supplies the scapular region. Then anterior circumflex humeral artery will give an ascending branch. So this will form a arterial circle around the surgical neck of humerus, and it supplies the head of the humerus as well as the shoulder joint. Posterior circumflex, it will anastomose with the anterior circumflex humeral artery that is around the surgical neck, and it also supplies the deltoid and shoulder joint. Okay, so with this diagram and this thing will be more than enough to explain the axillary artery branches. Okay, so so when you summarize about the artery, so the things which you need to write will be artery, the origin of the artery. Okay, so origin, where its origin is. Okay, you can just mention as a point below the, that is as a continuation of the subclavian at the outer border of the first rib. Okay, outer border of first rib. Then you will write about the termination. Okay, so where it terminates at the lower border of the teres major muscle. So termination. Then you talk about its course and parts. So the muscle which divides it. So that is an MCQ question. The muscle which divides the axillary artery into 3 parts. Okay, so it is the pectoralis minor muscle. Okay, so that will divide. Then you talk about branches, even branches, the branches from the third part are all except, like that question can be asked. So it's an MCQ again. So branches you mention of the first, the second, and the third part. Okay, and you write the area of supply. Right, so that is how we summarize the artery. Okay, so next relations. Yeah, relations also you need to write about the first part, second part, and the third part. Right, next is mammary gland, a very important long essay question. So mammary gland, when we write, you have to know the location and extent, the structure, in brief, and blood supply, lymphatic drainage, and applied aspects. So location and extent, when we say, so it is located in the pectoral region, okay, extending from the second rib vertically. It extends from the second rib along the, okay, so mid-clavicular line. No? So from the second rib up to the sixth rib, it extends vertically. And this thing from medial to lateral, it will extend from the lateral border of the sternum medially to the mid-axillary line, okay, laterally. So that is the extent of the mammary gland, and it also shows a small extension into the axillary region as the axillary tail of Spence. Okay, so this is you need to mention. So the structures it lies, since it is a mammary gland is what? It is a modified sweat gland. Okay, so it is present in the superficial fascia in the pectoral region. So whatever the structures are beneath it, it forms the mammary bed. Okay, so they are the pectoralis major muscle, the serratus anterior muscle, and the external oblique muscle of the abdomen. So all these muscles, they form the bed of the mammary gland. So deep relations, so deep it is related. So there is a space here. This is known as the retromammary space. So beneath that will be the deep fascia, that is the pectoral fascia and the pectoralis major muscle. Okay. And here it is anchored, okay, through these, what we call it as the ligaments, suspensory ligaments of Cooper. Through that, it is attached to this fascia here, okay. So when we see this and the axillary tail of spine, so I told you it extends into the axilla. This is an extension. That is basically because during the development, it develops from, there is the mammary ridge, which will be extending from the axillary region up to the groin region. So along that region, the mammary gland actually develops. So in humans, it just develops in the upper region, whereas in animals, you can see it will be it will be extending from the axilla up to the groin region. So here the skin of the skin of the mammary gland, it is pigmented, okay, and there is a projection which we call it as the nipple. It is so here on the skin we see these Montgomery tubercles are seen. So there are these sweat glands present there. Okay, so they also help in the lubrication during during lactation. So here beneath that, okay, so the stroma. Okay, stroma is made up of fibrofatty tissue as well as the glands. So in a lactating woman, these glands are well developed, okay, whereas in a non-lactating woman, it is more of the fibrous tissue and this fat. Okay, so these fibrous tissue, they will anchor the mammary gland to the underlying fascia, that is the deep fascia, through these ligaments, which we call it as the suspensory ligaments of Cooper. Okay, and these ligaments will be also, they will be dividing this entire parenchyma into lobes and lobules, you can see. Okay, and these glands, they open, the duct of these glands, okay, the excrete, it opens into a sinus. Okay, it shows a dilatation before it opens into the nipple, that is known as the lactiferous sinus. And this lactiferous sinus, during the period of lactation, it will be storing the milk for some time. Okay. So this is how you can just draw one schematic diagram and show the structure. Okay. And arterial supply, it's very important. So arterial supply is mainly by the branches, okay, from the internal thoracic artery branches, the posterior intercostal artery, as well as the branches from the axillary artery. So if you see here from the internal thoracic, we have the perforating branches. That is the second, third, and fourth space. The perforating branches of internal thoracic artery, they supply on the medial side, and above it is supplied by the branches from the first and second parts, if you see here. So superior thoracic artery branch from the first part of axillary, and pectoral branch of the acromiothoracic artery, which is from the second part, as well as lateral thoracic artery, which is also a branch of the second part. And then here laterally we have the lateral branches of posterior intercostal artery. So these are the arteries which supply the mammary gland, and the venous drainage, it corresponds to the same named veins. So from this medial side, it drains into the internal thoracic vein. Okay, this side it will so basically around the nipple, no, here in the areola, it forms a venous plexus. Okay, so from there, which is known as circulus venosus, and from there it will be draining into all this, and it also goes to the posterior intercostal vein. Okay, and from there it is draining to the azygous vein. So that is the venous drainage. So lymphatic drainage. So lymphatic drainage, here the lymph mainly drains into the axillary group of lymph nodes. In addition to that, it can also drain into supraclavicular group of lymph nodes and internal mammary lymph nodes, as well as posterior intercostal nodes. So mainly it is to the axillary group of lymph nodes. Okay. So these lymphatics which drain the mammary gland, they are grouped into two, the superficial and the deep. So superficial drains the skin region except for the areola and the nipple, whereas the deep, it drains the areola and the nipple as well as the parenchyma. Okay, so from the medial region, okay, so from the medial quadrants, right, the superior and inferior medial quadrants here, the lymph goes to the internal mammary group of lymph nodes, or we otherwise called as parasternal group of lymph nodes. So here what happens is the lymphatics from the right side, they communicate to the left, left communicates to the right. So that is why if there is any carcinoma, it can spread on either side. Here from above, it can go to supraclavicular group of lymph nodes and the apical group of lymph nodes. This side, it goes to mainly to the lateral axillary group of lymph nodes. Okay. So here, if you see, it goes to the lateral, anterior, posterior. So mainly to the anterior, then to the central group. From here, it will drain into the central, from there to the apical. So like that, as well as to the posterior group, it drains. Okay. Then posterior intercostal. And here from the lower quadrant, you should also remember it can go to the sub-diaphragmatic group of lymph nodes or subhepatic group of lymph nodes. Okay. So sometimes from here, wherein there is malignancy, cancers can spread to the ovary through this, that is through the coelom, that is the peritoneal cavity. It can spread to the ovary. So clinical correlation, abscess is common in lactating women. Okay, fibroadenoma of the breast, it is basically benign enlargement of the glandular tissue there, that is fibroadenoma. And then we have the malignancies, which is common. So malignancy is common in the right upper quadrant of the breast, whether it is left or right, the right upper quadrant is more common. Okay. Then the next will be the upper inner quadrant, then lower outer quadrant and lower inner quadrant. Around the area on the nipple is the second highest where the cancer can begin or malignancy can begin. Okay. And this is Krukenberg. So sometimes they ask you the clinical correlation there. Okay. So or give the anatomical basis for the spread of tumor to the ovary. So here what happens here? So I told you, so from the subhepatic or subperitoneal group of that is lymph nodes, it can go through the transcoelomic spread to the ovary. When the secondaries of secondaries means when the malignant from the primary site, it spreads to any other site, that is known as secondaries. So the secondaries seen due to breast cancer, that is mammary gland malignancy in the ovary, we call it as the Krukenberg tumor. And basically it is because of the transcoelomic spread, okay, from the subdiaphragmatic or subhepatic group of lymph nodes. So mammary gland, you will write about the definition. Okay, so first thing you have to write about the definition. Then you will write about the location, okay, where it is located, location and extent. And then you mention about the structure in brief. The mammary bed, it can be asked as an MCQ question. Okay, so briefly you mention about the structure. Then you talk about arterial supply and venous drainage. Arterial supply is very important. Then you have to write about lymphatic drainage. Okay, so there's basically the superficial and the deep. So superficial goes to where and deep goes to where. Both needs to be written. And finally, you talk about the applied aspects. So when you write about applied aspects, the common things which we see should be written first. Okay. So abscess, then we have fibroadenoma, which is a benign tumor. Enlargement we can see. So usually it corresponds to the premenstrual time and then it decreases in size basically because of the hormonal regulation there. Okay. And then we see malignancy and Krukenberg tumor. About Krukenberg, it's very important. We need to mention. Okay. Right. So moving on to the next question, elbow joint. So any joint has to be written under these headings: type, articular surfaces, ligaments, movements, and applied aspects. So here the articular, okay. So elbow joint is formed. Okay, what type of, it is a type, what type of joint? It is a hinge joint. Okay, it's a hinge joint, synovial type of hinge joint. And that is among the synovial joints, it belongs to the hinge joint type. So hinge joint type of synovial joint. And Why is it a synovial joint? Because it is covered by a capsule and lined by the synovial membrane. So here it is formed, the articular surfaces are the capitulum of the humerus and the capitulum and the trochlea, okay, of the humerus, and the head of the radius and the, this thing, what is this? Radial notch, okay, of the ulna. So all these things will articulate with the uh, humerus, this part, okay. So this capitulum, it articulates with the head of the radius, whereas the trochlea, okay, articulates with the trochlear notch here. And here there is one more joint here, because this is the elbow joint. The superior radioulnar joint will be between the radius and the radial notch of ulna. Okay, sorry, here I said this is the trochlear notch. Okay, so trochlear notch with the trochlea and the capitulum with the head of the radius. So this joint, we call it as the elbow joint. So that joint stability is maintained by the ulnar collateral ligament. Okay. So it gives two bands, that is the anterior and posterior bands. Near the medial epicondyle it's attached and keeps the joint stable. The other one on the lateral side will be the radial collateral ligament and annular ligament. Annular ligament will be around this, okay, holding this radius. So these will be providing the stability to the joint. Now this elbow joint, okay, here it forms what we call it as the carrying angle at the elbow joint, okay. So what is that carrying angle? It is the angle formed between the long axis of the humerus and the axis of the forearm. So that is the arm and the forearm. So here, no, it is more in females. Okay, it is about 10 to 15 degree away from the median plane. Okay, means from the from the body, it will be about 10 to 15 degree away. Whereas in males, it is about 5 to 10 degree away from the median. That is mainly because of the wider pelvis. Okay, in females, the wider pelvis, the angle will be more here. Okay, since why it is called carrying angle is, so when we are holding a bucket like this, our arm automatically goes in this position. Then other things is, so normally this angle, so if there is angle more towards the outward deviation, we call it as the valgus, and towards inside, we call it as the varus. Okay, and this one, usually the elbow joint, no, near the olecranon process, it is prone for bursitis. Okay, that is basically why it is called as student's elbow, because when they are studying, they will be keeping the elbow on the table for a long time, and that can lead to this bursitis condition. And supracondylar fractures are very common in the elbow joint there, just above the condyles, that is humerus. Supracondylar fracture can lead to Workman's ischemic contracture, basically because it's a deformity of the forearm, wrist joint, and the fingers. So basically because of the ischemic contracture. Then we have inflammation of the medial epicondyle, where we have the common flexor origin, or inflammation of the lateral epicondyle, which forms the common extensor origin. So this one is called as medial epicondyle. No, that inflammation, we call it as the golfer's elbow, whereas the lateral epicondyle, we call it as the tennis elbow. Other important thing which you need to know around the elbow joint is the anastomosis formed. So here the branches of the brachial artery as well as the branches, basically it is formed between the branches of brachial artery. But from above, we have the branches coming directly from the brachial as well as the profunda brachial artery. From below, it is from the branches of radial and ulnar, which are in turn branches of the brachial artery. So this anastomosis is seen around elbow joint, and it basically forms a collateral circulation there, especially if there is any ischemia or anything of any part of the artery. This anastomosis will help in the blood supply. So here, this is an easier way to remember. So what you can do is, you can make columns and write, okay, anastomosis around the elbow. So you will write okay, the location, and you will write branch from the, okay, branch from brachial and branch from ulnar brachial or profunda and branch from ulnar or radial. Okay. So first is superior-medially, then superior-laterally. Okay, two fair. So superior-medially here what happens? Branch. Okay, so from the brachial artery. So brachial artery, see if you see here, which is the branch from the brachial artery. So anteriorly and superior-medially. Okay, anteriorly and superior laterally. Then same way we have posteriorly and superior medially and posteriorly and superior laterally. Okay, so this how it forms. So anteriorly here, superior medially, we have the inferior ulnar collateral artery. Okay, inferior ulnar collateral. Okay, collateral is like, having it is like a bypass road. Okay, you have the main road and which goes to the same destination, and there is a bypass road which also goes to the same destination. So that is the collateral. So this is the inferior ulnar collateral. It will anastomose with the anterior ulnar recurrent artery. Okay, recurrent artery is like, taking a detour or a U-turn and coming back. Okay, so because artery is also already given here, but this artery will take a U-turn and come back again. So this is known as the anterior. This artery is called anterior ulnar recurrent. Okay, so that is in front. Posterolaterally here and anteriorly, we have the posterior descending branch, anterior descending branch of profunda brachii, okay, anteriorly and this thing, superolaterally. So anterior descending branch of profunda brachii and radial recurrent artery from the radial. Okay, so they will anastomose. Posteriorly, it is from the posterior ulnar recurrent and the superior ulnar collateral artery. Okay, they form behind. Here posteriorly, posteriorly and this place, we have the posterior descending branch of profunda brachii and the here posterior. So if you see here, this is the interosseous recurrent artery, which is a branch from the posterior interosseous artery. Okay, interosseous recurrent. So they form the anastomosis. So this is about the anastomosis around the elbow joint. Okay, so when you joint, so what are the headings you will write it under? So joint means you have to write first what type of joint it is, then which are the articulating surfaces or articular surfaces. Okay, then you write about the supports of the joint, okay, which includes the ligament and capsules and all those things. Then you talk about the movement here of the joint is, since it's a hinge type of joint, it brings about the flexion and applied aspects you mentioned. Okay, so those are the things which you need to write for a joint. Right, next we go to cuboidal fossa. Okay, cuboidal fossa, now when we see, okay, so you will explain it under location, boundaries, contents, and applied aspects. So location is where it's a triangular fossa or a triangular depression in front of the elbow joint, right? Anteriorly, the elbow joint. So that is the location. So clinically, this cuboidal fossa is very important because many nerves and arteries, vessels are in relation there. So we'll see that. So first coming to the boundaries. So when we say boundaries, we have, since it's a triangle, it will have a base, it has an apex, it has a medial border, and it has a lateral border. In addition to that, there is a roof and the floor. So you need to mention all. Okay, so boundaries always, when a triangle comes, not only the medial lateral boundaries, you have to also mention about the roof and the floor. So here the base, okay, or the superior border is formed by an imaginary line between the two epicondyles. Okay, medial and lateral epicondyles. So medial border is formed by the lateral border of pronator teres and lateral border is formed by the medial border of brachioradialis muscle. Okay, so brachioradialis here and the lateral border of the pronator teres, they form the boundaries. Apex is formed where the medial and the lateral borders meet. Okay, so this is the thing. So this will be the apex. So that was of the left side. Here you can see of the right side. So brachioradialis, pronator teres muscle. So this is radius, this is ulna, and this is the base. Okay. The floor is formed by in the upper part, it is the brachialis muscle, and in the lower part, it is the supinator muscle. Okay, supinator. So upper part, brachialis, and lower part, it is formed by the supinator muscle. Okay. So next you will talk about the roof. So roof, we have the skin, superficial fascia, and the deep fascia. So in the superficial fascia, we will see the formation of the median cubital vein by the cephalic vein and the basilic vein. Okay. In addition to that, there are many nerves also in that region. So you will see the lateral cutaneous nerve of forearm, the medial cutaneous nerve of forearm. Okay. Here, medial cutaneous nerve of forearm, and medial and lateral cutaneous nerve of forearm. Okay, so these are the and well as the bicipital aponeuris. This is one more structure which you will see here. Okay, so if you go from medial to lateral, when we go, it is the medial cutaneous nerve of forearm. Okay, medial cutaneous nerve of forearm, medial to lateral when we go. So this is the basilic vein. Then we have the median cubital vein. Okay, the lateral cutaneous nerve of forearm, then the cephalic vein. Contents. So contents from medial to lateral, we will say, the contents the common mnemonic here is MBBS. Okay. So MBBS means from medial to lateral, the median nerve. M is for median nerve, B is for brachial artery, the next B is for the bicipital tendon. Okay, that is the tendon of biceps brachii. Then S is for superficial branch of radial nerve. Okay, so you can see. So MB, B, yes. So why this cubital fossa is important is, since there are like brachial artery, then we have these nerves also. Brachial artery, basically it's present there. So we measure the blood pressure there. The median cubital vein, which is present in the, so what is that? Roof, right? So in the roof, it is present. So here from the median cubital vein, we draw the blood, okay, for any investigations, or we can also give intravenous injections there. Okay, so that is its importance. So any triangle or so cubital fossa. So you are going to write under what headings? First is where it is located. Okay. And then you will talk about its boundaries. And then boundaries include floor and roof. Always remember that. Okay. And then we have the contents. You'll write about the contents and write about its applied aspects. Next is brachial artery. So brachial artery, any artery, you have to write origin, termination, course, branches, lip applied aspects. Okay. So origin, from where to where? So origin is from the lower border of the teres major muscle, and the termination is in that was in the axilla, right? And termination here, it is in the cubital fossa. It's in the cubital fossa near the neck of the radius, where it will divide into two parts, radial artery and ulnar artery. Okay, so that is the termination. So you will write under these headings. So course, so it begins here from the lower border of the teres major muscle. So runs in the anterior compartment. Okay, it runs in the anterior compartment, and here it becomes slightly medial. Becomes medial. and it will end in the cubital fossa by terminating into radial and ulnar artery. Okay, so it will give many named branches in the forearm. Okay, so here you can see at the insertion site of the coracobrachialis, this is the common site for its compression. Okay, brachial artery can be compressed there because there it becomes a little more superficial. So blood pressure is measured there, and you can also feel for the pulsations. Okay, feel for. So this is a supracondylar fracture, can lead to rupture of the brachial artery. Okay, so artery, brachial artery, you will write about. So you have to write the origin, where it originated. Then where it terminates in the cubital fossa. Okay, its branches. They are radial, terminal branches are radial and ulnar artery. Okay, and other branches will be these. It gives, sorry. Okay, it gives nutrient artery. It will give a nutrient artery, superior ulnar collateral, inferior ulnar collateral. Okay, and the largest branch is the profunda brachii artery. Okay, profunda brachii artery. So profunda brachii artery, superior ulnar collateral, inferior ulnar collateral, and nutrient artery. They are the branches. And terminal branches are, of course, radial and ulnar. Okay, so branches you will write, applied aspects you can write. So branches as well as applied aspects. You need to mention. Okay. Next is radial artery. So radial artery origin. Where is the origin? Where the brachial artery ended, radial artery is beginning, right? So radial artery begins near the neck of the radius, okay, near where the cubital artery would have terminated. No? So there it begins. So when we see, so where it is ending, it will end in the near the wrist joint. Okay, it will end near the wrist joint and in the palm. Okay, after near the wrist joint, where then it passes into the palm and it will terminate by forming the arches. So course and thing. So course here, once it is given by the brachial artery, this radial artery will run deep to the brachioradialis. Okay, so this you can see brachioradialis muscle. So it will be running deep to the brachioradialis muscle on the lateral side. Okay, that is in the upper 2/3. In the lower 1/3, what happens is this artery will become superficial. Okay, where it is covered just by the skin superficial fascia and little deep fascia, it is covered here. Okay, it's more you can feel. That is why you feel the radial pulse here. So it will be lying against the radius. Okay, so it will be present here. So once it reaches here, that is near the styloid process, of the radius, here it will give the superficial palmar branch. And then it will wind around the wrist joint and it will go posteriorly. Okay, it goes posteriorly, that is into the dorsum of the hand by passing in the anatomical snuff box. So here is the anatomical snuff box. So here it passes and then enters again the palm by passing between the base of this first and second metacarpal and first and second dorsal interosseous muscle. Okay, through that it passes. So there it will, once it enters the palm, okay, the radial artery will give the princeps pollicis artery and radialis indicis artery. Okay, so these will contribute also to the superficial. This lighter one is the superficial palmar arch. So it will contribute these branches from this princeps pollicis artery, which supplies the thumb, as well as the radialis indicis artery. Okay, and it will end by anastomosing with the deep branch of ulnar artery, which will form the deep palmar arch. So that is the course of the radial artery. Understand? So Applied aspects, you will write about feeling the radial pulse. And another thing what we do for radial artery is, see, usually we take the venous blood, no? But here for radial artery blood, any investigation, we take venous bloods, okay? But radial artery blood is taken for ABG, that is arterial blood gas analysis, okay? So this is what you need to know. Then we have posterior interosseous nerve. Now, what is posterior? Posterior interosseous nerve. So, posterior interosseous nerve is otherwise, okay, also called as deep branch of radial nerve. Okay, posterior interosseous nerve. So, nerve also you will write in the same pattern of origin, termination, course, branches, applied aspects. Okay, so the radial nerve will divide, okay, once it enters, no, that is from the posterior compartment in the lower 1/3 of the humerus, no, it will come from the posterior to anterior part of the arm. So once it comes there near the head of the radius, it will divide into two branches. There's a superficial branch and a deep branch. So superficial branch, you will see it as a content of the cubital fossa. Whereas the deep branch, it will pass, okay, between the two heads of supinator muscle. So supinator muscle here comes from the lateral, that is, it has a humeral head coming from the lateral epicondyle as well as the supinator crest of the ulna. Okay, fossa and supinator crest. From there it originates and it gets inserted into the upper lateral 1/3 of the radius. Okay, so in the upper 1/3 of the radius along its lateral aspect, it gets inserted. Okay, sorry. This supinator muscle will be inserting. So this nerve, it passes between these two heads of the supinator muscle. So once it passes, it enters the posterior compartment of the arm. Now, posterior compartment of the arm is the extensor compartment. And this posterior interosseous nerve is completely motor, supplying the muscles. Okay, it is motor nerve. So it passes through the course, that is between this radius and the ulna. In relation to the interosseous membrane, it will be running deep to the muscles. And there it will end. Okay, passes beneath the extensor retinaculum of the, and that is the fourth compartment of the extensor retinaculum, where it will end by forming sometimes a pseudoganglion. Okay, so basically it's an enlargement. Sometimes it will be painless, or sometimes since it is in the region of the wrist joint, it can form, it can pain also. Okay, if it is painful, then you need to intervene. What is that? Accordingly, based on the symptoms. Otherwise, it is not as such painful. Okay. So, posterior interosseous nerve. So, it is the deep, otherwise called as deep branch of radial nerve. Okay. So, where it begins, you will write. Okay. Terminates where? Termination. After that, you will write the course of the nerve. Okay, so branches basically it is completely, it's a motor nerve. Okay, so that is how you term. So basically, if the nerve is injured, the action of the muscles is lost. Okay, then we have wrist joint. So wrist joint here. Okay, so again, like any joint, type articular surfaces and ligaments, movements, applied aspects. Okay. So wrist joint is like, it's a synovial joint, saddle type of synovial joint. So here the articular surfaces, okay, you should know it is formed between the radius, the scaphoid and the lunate. Okay. So these bones, they form the wrist joint. So here we have the radial collateral ligament. Okay, you can see this is the joint actually. So the ligament supporting the joint will be the palmar radiocarpal ligament and the dorsal radiocarpal ligament. Okay. So the palmar radiocarpal as well as the dorsal radiocarpal and the radial collateral ligament. So these are the ligaments which will support the wrist joint. So basically the wrist joint movement. So we can flex, we can extend. When we deviate, that is medial deviation, we call it as the ulnar deviation. And way the lateral deviation, we call it as the radial deviation. Okay. And pronation and supination. So those are the movements taking place at the wrist joint. So here two types of fractures we commonly see. One is Colles, another one Smith's, which we also called as reverse Colles. Okay. So here what happens when we usually give the cases like that fall on the outstretched hand, that will be the history. So here the fracture, distal end of the radius, and there is upward and backward displacement of the distal fragment. So this is called as the Colles fracture. In this, what happens is there is lower end distal fracture, okay, the lower end, but the distal fragment is dislocated anterior and forward here. Okay, that is known as the reverse reverse Colles. Colles is this one. So this, if you see here, it gives a appearance of dinner fork. Okay, like little bend like this, dinner fork. So it's also called as Colles fracture is also called as dinner fork's deformity. Okay. Another thing here is the scaphoid. Scaphoid bone is more prone for fracture there, and lunate bone, if it fractures, it can go in for necrosis. Okay, because what happens is if the fracture site is across the bone, the artery which supplies will be only to the one fragment, that is the proximal fragment. Okay, that fragment, because it will not cross to supply this distal part. So because of that, this distal part which will lose its blood supply will result in necrosis. Okay, so so this wrist joint, other name for the wrist joint, okay, we also call it as the radiocarpal joint. Okay, so anything is asked, radiocarpal joint or wrist joint, you have to write about the same thing. So you'll write the type and all. Another MCQ question which is asked is common carpal bone to be fractured, that is scaphoid, and common carpal bone to undergo necrosis, that is the lunate. Okay, so those are MCQ questions which are asked there. Then coming to the short answers. So first is serratus anterior muscle. So any muscle, we have to write origin, insertion, nerve supply, and action, as well as clinical importance if any is there. Okay, so origin of the muscle. Okay, so the muscle originates from which one? It originates from the first to eighth rib. By 8 digitations, it originates. Okay, so here the upper one, it gets inserted to that is basically along the medial border of the scapula. Along the medial border, all these 8 digitations, medial border as well as the inner surface, that is the costal surface of the scapula, it will get inserted. Okay, so from the extending from the superior to the inferior angle. The nerve supply for that muscle is the long thoracic. So you can see this is the long thoracic nerve of bell. Okay, it supplies the muscle. So basically the muscle brings about, the serratus anterior, it will, during the pushing movements, pushing or climbing, that is why that muscle is also called as climbing muscle. So it will help in pulling forward the scapulae. Okay, so like that. So that is serratus. See, when you do push-ups, when you pull forward, when you push against force. Okay, so this is the muscle which will bring forward the scapula. So basically for pushing, we use the muscle. Okay, so that is about serratus anterior. So when the long thoracic nerve is injured, then serratus anterior muscle is affected. Next is supinator muscle. So again, same thing, origin, insertion, nerve supply, action you have to write. So origin, 2 heads it has. So the that is the humeral head from the this thing that is from the humerus, it comes from the condyle, okay, whereas the ulnar head comes from the supinator crest, okay, that is from the lateral epicondyle. This is from the um, crest, and the supinator fossa, that is from the ulna. So both the heads will fuse and they get inserted into the lateral aspect of the radius in the upper 1/3 part. Okay. So the nerve supply is basically, since it is muscle of the back of the forearm, it is supplied by the posterior interosseous nerve. Action is it brings about the supination. Okay, supination of the forearm. So that is about supinator muscle. Then we have trapezius muscle. So trapezius muscle here. Okay, so trapezius muscle is a very important muscle here if you see. So origin, insertion, nerve supply, action. So same thing, you have to write it under. Okay. So if you see this muscle, it has got a very wide origin. Okay, so all along it is into three parts: upper part, middle fibers, and the lower fibers. Okay, so when we see here the upper fibers are coming from the external occipital protuberance and medial 1/3 of the superior nuchal line, as well as the ligamentum nuchae extending up to the spine of C7. And it is getting inserted to the lateral aspect, that is the clavicle, okay, then to the acromial process and to the spine of the scapula. The middle fibers here, they are coming from these spines, okay, C1 up to C1, C7 up to T1, T2, we will have the middle fibers. So middle fibers, they get inserted into the spine of the scapula. The lower fibers are coming from the spines of all the thoracic vertebrae here, if you can see, as well as the thoracolumbar fascia is here. So from up to T12. Okay, so from all the thoracic vertebrae, it comes. A little from the thoracolumbar fascia. So from here, it gets inserted into the, what we call it as the delta tubercle. Okay, not tuberosity, tubercle, which we see on the spine of the scapula. So there it gets inserted. So the nerve supply is basically by the spinal accessory nerve. Okay, spinal accessory nerve will supply the trapezius muscle. Okay, you can see how it innervates the trapezius muscle. So what does the trapezius muscle do? So the different fibers, okay, so it brings about the, like, when we have to abduct beyond 90 degree, okay, the arm above the head abduction, it lifts the shoulders, okay. So it brings about this shrugging of the shoulders, as well as the abduction. So clinical testing is, we ask the patient to shrug against force. Okay, we apply pressure, and against that pressure, they need to, excuse me, shrug the shoulders. So if they are able to do that, that means the muscle has the power there. Okay, so that is about trapezius. Then we have coracobrachialis. Coracobrachialis is a very important muscle here. Okay, so same thing, any muscle, origin, insertion, nerve supply, action, and clinical importance. And in coracobrachialis, there are two more things which you need to add. One is its morphological importance, as well as the events which are occurring at the insertion of the coracobrachialis. So here, origin is from the tip of the coracoid process. So tip of the coracoid process, along with the short head of biceps, it has a common origin here. Okay. And it gets inserted into the anterior and medial, that is shaft of the humerus. Okay, so it is almost about middle portion of the medial border of the humerus. Okay, middle of the, so there it gets inserted, this muscle. So morphologically, we say that it had its third head also. So third head, it later formed the, what we call it as the Struthers ligament. So Struthers ligament will extend from a supracondylar process up to the medial epicondyle. So sometimes this brachial artery median nerve, they pass beneath the the Struthers ligament, and it can lead to compression. So this is known as the third head of the coracobrachialis. That is important. Okay, next is the events occurring at the insertion of coracobrachialis. So coracobrachialis is getting inserted into the middle part, no, that is of the medial border of the shaft of the humerus. So what happens here is the circular at that level, no, where it gets inserted, the circular shaft of the humerus, it will become triangular. Okay. Then the brachial artery will pass. Okay. So the brachial artery will pass from the medial side of the arm to the anterior aspect. Then basilic vein, here basilic vein will pierce, okay, the deep fascia. So basilic vein, no, it is a superficial vein, right, in the forearm. So at this region, it will pierce, it will go pierce the deep fascia and enter deep to the forearm, where it will contribute to the formation of the axillary vein. Then median nerve. So median nerve here, it crosses in the front of the, so median nerve will cross in front of the brachial artery from the lateral to the medial side. Then radial nerve, it pierces the lateral intermuscular septa, and it will pass from the posterior, okay, radial nerve here. So lateral intermuscular septa, it will pierce and it will pass from the posterior compartment to the anterior compartment. Ulnar nerve here, which lies in the anterior compartment, will pierce the medial intermuscular septa, and it will enter the posterior compartment. Okay. Then medial cutaneous nerve of the arm, and the forearm will pierce the deep fascia to become superficial there. And nutrient artery will pierce the humerus. So these are the events which occur at the insertion. So this is separately is asked as a 3-mark question, or some of these events, they can mention it in an MCQ and ask you whether they are true or false, or it can be also asked like, all are true about the insertion events occurring except, so like that. So what does this muscle do? So it brings about the, it is a weak flexor, okay? It brings about weak flexion of the arm, that is as well as it will also cause adduction. Okay, it brings about adduction as well as is a weak flexor. So that is the action of the muscle. Okay, so it is so this is how you will summarize or write the under these headings. You have to write about the coracobrachialis muscle. So with this, we finish today's class. Thank you for watching Auricle. If you haven't yet downloaded the app, you can get it on Google Play and App Store. And for more social, like you can follow the social media handles for more content. So we are on YouTube, Instagram, whereas Facebook, as well as the Telegram. Okay. So until next time, bye.